Good afternoon, ladies and gentlemen. I must thank the Sri Lanka College of Endocrinologists for giving me this opportunity to talk to you about one of the important new therapies for our diabetic patients. To illustrate, I have a case here. It's a 68-year-old lady with long duration of diabetes, 15 years, and with hypertension. But she doesn't have any macrovascular complications like angina, TIA, PVD. But she has nephropathy, she has non-proliferative retinopathy and peripheral neuropathy. And she has gained about 5 kilograms with a bit of leg edema over the last couple of months. And she got admitted with a major hypoglycemic episodes mid-morning, and then she admits having similar but less severe hypoglycemic episodes at night as well. And her BMI is 28, obese, blood pressure is 140/80. These are the investigations. You can see the ACR is fairly high. It is in the range of macroalbuminuria. And then you have total cholesterol, which is again above the target, and the EGFR is 50, which is low. So she's in some degree of CKD. And her blood sugar is 180, with HbA1c well above our targets for anybody with diabetes. And she's on a good dose of insulin, premix 50 in the morning, and some lunchtime slow-acting insulin, and the maximum doses of glycoside, metformin, sitagliptin, and losartan, and atorvastatin for blood cholesterol. Now, our decision on what to select on this patient is based on the patient factor. So this is one of the new things that came up in the new EASD guidelines, that we focus on the patients as an individual before deciding on the treatment. Because this approach itself can bring down your HbA1c by maybe 2% if you improve the adherence of the patient to whatever the therapy that you are going to give. So here we are talking about patient's engagement right from the beginning, acceptance of the particular medicine for the patients, and a plan and follow-up of the patient throughout the illness with some sort of a care plan. So it comes first in this case. And let's go back to the key characteristic of this patient. So this patient has had diabetes for good 15 years. So this is not the brand new diabetic patients that you see in UK-PDS trial, where you randomize the patient as the diagnosis is made, and that shows a different outcome when you employ the treatment. But as your duration of diabetes is longer, you fall into a different subset of group of patients who won't show the same benefits with the same treatments, like in a cohort trial. So the duration of diabetes is very important, because most of these patients have established cardiovascular risk, whether they are there, like angina, or sometimes they may not be there, but still they will be there. So their cardiovascular risk is fairly high, and we should consider that as well in deciding a treatment for these patients. And diabetic nephropathy is the most important pick in this patient, because she has gained 5 kilograms with a bit of edema. So she's in hyperfiltration stage with diabetes nephropathy, right, with proteinuria. And there, your renal functions, it may be okay right now, but after some time, as you know, the proteinuria level will go down as your glomerular numbers comes down, and then you slip into chronic renal failure, where we have nothing other than renal replacement therapy. So the treatment that we are talking about here should address the nephropathy or reduce the progression of the nephropathy in this patient. Hypoglycemia again is very important. Patient has already had hypoglycemia. So if you try to intensify the insulin treatment, that is going to cause more hypoglycemia. Again, the weight gain itself is an independent risk factor for any complications of diabetes. So we have to be cautious. Now we'll get back to the EASD, the new EASD algorithm. You can see that the metformin has established its position for a long time now, so we can't talk about that much. But now, from 2008, you need CVOTs for any drugs to be recognized or get the FDA approval. So these new drugs will start with cardiovascular outcome trials, so which is a very good thing, which we can talk in a while, in a bit more detail. So our patient falls into the left-hand category where there is increased cardiovascular risk. So about 25% of your patients will be in this category, right, even at the diagnosis. So that is a very important determinant. So if we dissect this into further, this is the EAC guideline. So those with established atherosclerotic cardiovascular disease or CKD, they go in a different algorithm after metformin. So in this patient, it is mostly a CKD type of picture with a slightly reduced GFR and proteinuria. So the options are different. It should be SGLT2 inhibitors if the patient tolerates or if there are no other contraindications. So these are the therapies available, so we can't complain. There are plenty of therapies available, but as you know, most of them are insulin centric, or they will increase the insulin level directly or indirectly with the side effects. But what we are talking about here is SGLT2 inhibitors, the action of which is independent of insulin, and it is it's nothing to do with pancreas and insulin secretion. So it just takes your glucose away from the system and make it a very conducive environment for the cells. Now it is not a new thing. So this has been known for 150 years, where people actually researched on this substance called fluorescein, which is actually a SGLT2 and SGLT1 inhibitor, which is found in the root bark of the apple trees. And then it was subsequently isolated, but still it didn't come to the market because there were a lot of problems, because it was not bioavailable. So you don't have to be fascinated about eating green apples because it is not going to be bioavailable. But it has both SGLT1 and SGLT2 effects. SGLT1 is predominantly in the intestine. So if you block it, you develop diarrhea because a lot of glucose will be in the system. Now, when you look at the SGLT2 inhibitors, the nephrons, the action of the SGLT2 inhibitors, you filter all the glucose through the glomerulus, about 180 grams of glucose per day. And in the first part of the proximal convoluted tubule, it is taken up, it's reabsorbed back into the circulation by an active transport through these SGLT2 proteins. So it's a low affinity but high capacity system where 90% of glucose re-enter into the system. And then you have SGLT1 accounting for about 10% of glucose reabsorption, leaving virtually no glucose in the urine. So from it's not only the glucose, it takes the water as well with the glucose. So from our medical student days, we know that the renal threshold for glucose is 180, but it is not so in diabetes. So if it is 180, fine. When you get diabetes, you will pee out all the glucose, but it doesn't happen. So in diabetes, your renal threshold also goes up. So renal threshold goes up so that you will have very low level of glycosuria, and it is a sort of a maladaptation of the SGLT2 proteins. But what the SGLT2 inhibitors do is it increases the fluid loss, glucose loss, up to about 80 grams per deciliter, 80 grams per day, by lowering that threshold down to about 40 to 120. So these are very useful drugs we are talking about, the mechanism of which is diverse. It's not really not only the excretion of glucose, but there is energy switch from glucose to free fatty acid. That's why you get a lot of weight loss and so on. So what are the cardiovascular outcome trials? There are three main trials that we talk about: EMPA-REG outcome trial, CANVAS trial program, and DECLARE-TIMI 58 program on these drugs: empagliflozin, canagliflozin, and dapagliflozin. Now the median follow-up of these trials is they are comparable, and patients had, most of them have established cardiovascular risk factors, but the renal functions were okay. Now outcomes, when you look at the renal outcome of these patients, you can see in EMPA-REG trial about 39% reduction in or incidence of worsening of worsening of nephropathy. They are very potent in terms of renal risk reduction, and CANVAS trial showed 40% risk reduction, and DECLARE-TIMI 58 on dapagliflozin showed about 24% risk reduction with regard to the renal endpoint. Now renal outcomes in SGLT2 inhibitors, it is not only for the patients with vascular risk factors, but across the board, the patients with vascular risk factors and without risk factors, they all get the benefit as it is shown in this meta-analysis appeared in Lancet this January. So, so they have extensively analyzed the data from these 3 CVOT trials, and this is another findings where you see that the effect on the renal function attenuates as your GFR drops. Like if you're in a lower category of renal failure, like your GFR is low, the efficacy of drug seems to be lower. So that is one of the observations that led to subsequent trial like Credence. Now, if I am to plot the renal functions, how you plot the renal functions of a patient into this grid. So you can categorize it according to the albuminuria, from microalbuminuria to macroalbuminuria, and we can categorize it according to the eGFR. Now, with these 3 trials, as you know, they looked at patients with preserved good renal functions. So they were okay, the GFR was above 60, but our patients, as you can remember, our patients had a slightly reduced GFR, and she does not fit into this category. She's a high-risk patient for renal failure, right? So then came the Credence study design, which is a straightforward 2,000 on each arm. They enrolled everyone with all stages of renal failure, and as low as 30 eGFR, and during the trial, if the renal eGFR falls, the patient remains in the trial, so that we could analyze the effects on the renal failure progression even down to the end-stage renal failure. So that is the design of Credence trial using canagliflozin 100 milligram. Right, this is the outcome. Primary outcome, end-stage kidney disease, doubling of the renal creatinine or CV death. It's very remarkable. You can see about 30% risk reduction in the Credence trial with canagliflozin in these high-risk renal patients. Now, it's not only in the patients with moderate renal dysfunctions, as I mentioned, those who with very low eGFR, less than 15, still had significant renal risk reduction according to the forest plot. This is, I have taken this from Credence, the original slide set. What about cardiovascular outcomes? Now, the meta-analysis of these 3 trials shown that the patients with established cardiovascular problems, disease, there is a very good benefit in terms of cardiovascular outcome. But as the patient's risk category changes, like patients with multiple risk factors alone, then that benefit is not seen. So, CV outcome across these trials, there is about 14% relative risk reduction in both EMPIRIC and CANVAS trial. And when it comes to renal death or heart failure, there is very much pronounced effect with this drug. So heart failure, when you analyze separately, you can see even the patients with history of heart failure or patients without heart failure, there is significant risk reduction by SGLT2 inhibitors. Now, to look at the efficacy of these drugs, so HbA1c reduction is comparable to injectables, GLP-1s and DPP-4 inhibitors. It's in the range of, let's say, 0.9 to 1%. And fasting blood sugar reduction is also like that. And then weight loss is the most important thing. You can lose up to 8 kilograms, up to 6 kilograms, but in trials it is been 3.3, significantly very high weight loss. Blood pressure reduction is more with systolic blood pressure than diastolic blood pressure. It's very beneficial up to about 6 milliliter Hg blood pressure reduction you can see. Now, what are the side effects of these medications? Now, the commonest side effects that we always talk about is urinary tract infection, so genital infection, which is true. But in subsequent trials, including Credence trial, that was not much observed, and it was very rarely that the genital infection led to discontinuation of the treatment. So the treatment was continued by treating. So UTI, osmotic diuresis, and renal failure with hypoglycemia, hypovolemia was also detected or shown in early trials like CANVAS trial in very early subset of elderly subset of patients due to dehydration. Actually, with these drugs, you will initially see, like in ACE inhibitors, you will initially see some reduction in EGFR, but after that it will improve when your hemodynamics and improves. And then there is reports about amputations. The amputation risk was going up with early trials, CANVAS trial, upper extremity amputations, partly explainable by bone mineral density loss that happens with these drugs. There are various mechanisms postulated. One of that is the weight loss itself accounts for about 40% of BMD loss in this subset of patients. I have a few slides about that. And then there is increased risk of fracture, amputation, and then there is this rare complications of diabetes ketoacidosis. This is again a peculiar type of thing. The mechanism of diabetic ketoacidosis here is different from the classic diabetic ketoacidosis we see, and this is mostly an acidosis rather than ketoacidosis. And the number of cases across the trials have not been sufficient to properly analyze actually as to what happens in this ketoacidosis. One of the mechanisms is that the substrate change, you increase the lipogenesis more than lipolysis, so that the lipids are taken up for energy, so and producing more ketones or acids. So that is one of the mechanisms. And there are FDA warnings on SGLT2 inhibitors. You can see that so many FDA warnings are there. The most recent one is on the necrotizing fasciitis of the perineal area, which is, I think, is a devastating condition if you get it. And so that is there. And then we'll talk about the Fournier's gangrene. That is again a very recent FDA warning with these drugs. This is a urological emergency. So a patient can have a very, very nasty experience with this. So the key to prevent this is to keep the genital area very, very clean and to increase the fluid intake, avoid dehydration, and if you notice any sort of redness or discharge or fungal infections, you have to seek the medical advice and get yourself treated. And amputations, as I mentioned earlier, actually there was a slight risk, higher risk of amputations noted in the CANVAS trial initially, but when you see the real world data, it looked different, right? And this is another analysis of the CANVAS trial itself. If you categorize these patients into high risk population, high risk CV risk population and low risk CV population, the risk of amputations were higher in high risk populations. But ultimately, when you compare this to non-SGLT2 inhibitor treatment group, there was no difference. And the Credence trial also disputed that there is an increased risk of low extremity amputations with the SGLT2 inhibitors. Now, this again meta-analysis again showed that there was no observed difference in risk of below knee low extremity amputations among canagliflozin or any other SGLT2 inhibitors for that matter. Right, now we'll get back to our patient. So our patient is a good, the ideal candidate for SGLT2 inhibitors because she is in early nephropathy, she has got fluid overload, weight gain, and she's on antihypertensives as well. So she was commenced on SGLT2 inhibitors. And why it was started on her? Because it's simpler for me, simpler for the doctor or the prescriber, and it is easier for the patients. It's not an injectable, so the acceptance rate is more, and it's just as effective on any major adverse cardiovascular endpoints, anything, and more effective on heart failure, which is a very high mortality scenario in diabetic patients, and it is more effective on chronic kidney disease. That is why this drug is preferred over GLP-1 receptor agonist, which was discussed by my colleague a while ago. And in summary, SGLT2 inhibitors are non-insulin dependent blood sugar lowering agents with many other favorable effects, blood pressure, weight, and so on. And they can be used in renal failure with favorable effects on progression. of CKD, which is shown in multiple trials, including the latest trial Credence. And they delay the onset of and progression of heart failure, which is a major contributor to CV mortality in any patients with diabetes. And most of the adverse effects seen in initial trials with these SGLT2 inhibitors were not substantiated in subsequent large CVOT trials or with real-time data. So thank you so much for listening to me. Thank you.